A continuación, desde Canadá presentamos al doctor Larry Ford con su charla Aceptar escuelas de CPAP secundarias al nivel 3 en la población primaria. Polisomnografía, Tecnóloga Registrada en Sueño, afiliada a la American Association of the Tecnologist y Canadian Sleep Society, cargos que tiene actualmente la directora del programa de entrenamiento de Tecnólogos de Sueño y directora del programa de sueño de la RST en Canadá. Bienvenida, doctora.
I just want to show you a quick video on how we handle obstructive sleep apnea here in Canada. If only that would work for everyone, that would be the perfect solution. The American Academy of Sleep Medicine has laid out several levels of testing. There's level 1 testing, which is attended polysomnography. Level 2 testing, which is a full polysomnography calibrated gently in the home. There's level 3 testing, which is called cardiopulmonary testing or portable monitoring, which includes aerosol efforts and oxygen saturation, and keeps the device home. Or there's level 4 testing, which is simple oximetry, which is probe on the meter, monitoring oxygen saturation and heart rate. With the growing obesity across the country, across the world, you know, it's much easier for people to go and McDonald's or fast foods than it is to buy healthier food. It's cheaper as well, so we have a higher incidence of obesity and therefore disordered breathing. So for disordered breathing, one of the things that we look at, this is your normal airway here. And I have to use my pen. And when somebody lays back and goes to sleep, you can see here that there is a narrowing of the airway. So therefore you have what's called partial obstruction. And that's when you have snoring, you might have have something called upper air resistance or hypoxia. When the patient lies back with a CPT, you can see that you have total obstruction or blockage of the airway, and that's when you have apnea. These apneas can be anywhere from a minimum of 10 seconds and can go all the way up to 1 minute or greater. This will cause 4% desaturation from their baseline level, and these can lead up to anywhere from up to 100 times every hour, and then you categorize them into mild, moderate, or severe sleep apnea. So, yes, I am going to talk a bit about sleep studies, so hopefully not everybody will follow suit. Level 1 sleep labs, they're definitely not new. They're not as old as Frankenstein, but they are been around for quite some time. Level 3 testing is relatively new, and there are many devices available. If there isn't a device that's better than the other, but we're having studies done to show which devices capture events better, snoring better, and respiratory events. Maybe the disrupted 4% or 6%, a little bit. So why already know that level 1 test the gold standard, so why would you bother to use a level 3 test? Where I come from, there's, in the province of Alberta, there are 3 million people, and we have 8 sleep levels. There is anywhere from a 1 to 2 year wait list for people to come in and have a level 1 sleep study. So using a level 3 testing works for us. If you can use it as a triage tool, and for those people that show that they have severe sleep apnea, they can get into sleep labs a lot quicker. For those that actually have disordered breathing, they don't have any comorbid medical problems, then they can set them up on CPAP and they are quickly treated. You can save the level 1 labs for more complicated cases for BiPAP or adaptive servo ventilation. Where you're left behind in the market store. So one of the things that evidence supports is portable monitoring can be used in the diagnosis of obstructive sleep apnea, and it indicated that in certain populations that it should be used as a triaging tool. One of the problems that we have with portable monitoring is often people are just sent to have one of the levels of testing, and we don't even know if they're appropriate candidates. And this can cause problems for them moving on to treatment. So if you go onto the website in the American Academy of Sleep Medicine, we have actually printed clinical guidelines for portable monitoring in the use of the diagnosis as well as the management of obstructive sleep apnea as an alternative to in-lab testing. By no means do they say it should replace level 1 testing. However, it can be used, and they actually lay out what are the guidelines for proper use of level 3 testing. They have also made, they've also made task force recommendations for when you actually are going to use portable monitoring, that you use the best practices, as well as the diagnosis of obstructive sleep apnea, that you should send them to a level 1 lab if the patient has significant comorbid medical issues. However, level 3 testing can be used, if the patient is immobile, they can't come to the lab, and just make sure that it is safe. The other thing that they recommend portable monitoring for, whether you've had an in-lab sleep study, oral appliances, or if they have the surgery, that you should use portable monitoring as a test to make sure that whatever treatment that they have been put on is actually working for the patient. One of the things you want to make sure that portable monitoring, it can be used in patients that have obstructive sleep apnea, and they have a moderate to a high pretest probability, which can be determined by their neck circumference, whether they snore, their BMI, and if in those instances, and they do not have any comorbid medical issues, that you can send them on to portable monitoring, as well as they should have a physician consultation. If you do not have those, then they should definitely send to level 1 testing. Some contraindications would be if people have comorbid medical conditions such as pulmonary disease, cardiovascular disease, and neuromuscular disease, then they probably are not going to be a good candidate for portable monitoring. And in those instances, if you do not have a sleep physician following them, they may be treated, and in those cases, they will be put on treatment and be very dangerous for the patient. The other, one of the contraindications listed is that patients that have other sleep disorders, such as insomnia, periodic rhythm movement, they will not be good candidates for their level 2 test. And the reason is that you're not even monitoring them, you're only monitoring the obstructive breathing component of the patient. One of the things that is also recommended is you need a team of trained professionals, whether they be polysomnographic technologists, registered respiratory therapists, as well as board-certified sleep physicians. And every one of those professionals has a role in portable monitoring. They will teach patients how to use it. They will educate them on making sure that it is put on properly. They will download the actual data on it to make sure that it is up to required before it is actually sent to the sleep physician. Then when the sleep physician, they will actually review the data again, and if it is required, they're able to make a good recommendation as to where the patient should be triaged next. Here at Respiratory Home Care Solutions, we do a lot of level 3 testing. As I mentioned, access to our level 1 lab is very difficult. We do across Canada, we do like 600 level 3s per month. We use many different devices over the course of the year, trying to find which one works for us. And over the last 10 years, we've probably done 30,000 portable monitoring tests. We've built a very strong relationship with our sleep physicians, so if our patients come back and they have issues or they really need to get into 11, waiving that whole treatment, and because of that, we can allow them to get into level 1 to up. Well, why does this matter to us? One of the things is we want to make sure that we have proper interpretation, therefore we have a board-certified sleep specialist or a few of them on staff. We want to make sure that we have trained professionals for appropriateness. That if you have a registered sleep tech, a respiratory therapist, they already know what are the things that we should be looking for in patients that will make them safe and receive treatment. We tested many devices, so therefore we know which device will work great for us. One of the things that we do, we want to make sure we close the loop. If anybody comes in, you do not have sleep apnea or you're not safe to receive treatment, you just don't kick them out the door and say, all right, we can't see you. We will send them off to the appropriate people. And that's what makes it a good, important that we want to have a good team involved in all the things that we're doing. Recently we did a study on patients. What we did is we used patients that were referred to us from the community. None of them were acute physicians, but they were just general practitioners out in the community. And we did a level discussion on them, and we wanted to see how many of them went to the CPAP trial, and these were quite uncomplicated those days. How we worked it is patients again were referred in primary care. They were had an assessment in the office by either an RST or an RPSGT. We showed the patient how to use the level 2 device. They took it home. We uploaded it off the interpretation to a board certified clinical specialist, and we sent us the results back. We did almost 700 patients. You can see we did almost double the amount of male and female. The mean AHI was 20 months. The average upward sleepiness was 10 out of 24. What our results showed that 144 of those patients had AHIs above 30, so they were severe. 147 in the moderate category, 238 were mild, and 168 ended up being within normal limits. From those 700 patients, almost 50% were an auto CPAP trial. Here in Alberta, we do a lot of auto CPAP, and for the reason that we do portion monitoring. Once they were put on therapy, the patients were called in every day. We then called them in a month to see how they were doing, and then they came in 1 month after they purchased their CPAP again to see how things were going. For those patients that did not follow through with treatment or in the mild category, we always need to again to send them to a sleep specialist just to make sure that their sleep issues that we originally came with were taken care of. At the end of the 1 month trial, and this is something that we actually tried ourselves in, that patients that were on trial, we actually came in, we actually downloaded their cards, and it showed 5 hours and 40 minutes, 93% of the time. And this was in 8% of the patients. The other 20%, they didn't come in by the time we ended up in study, or we just couldn't get a hold of them thereafter. We collected the data, and then 1 month again, we saw them at post-purchase, and it showed that the number of hours that they used it actually went up, 6 hours and 51 minutes, 97% of the time. And again, it was only 79% of the patients. So the national average for in the United States is 4 hours. 4 hours, 70% of the time. So we're very proud that we can say that we're well above those numbers. In the conclusions of the actual study, of the 349 patients that actually went on trial, 69% of them purchased CPAP, 20% of them at the time of the study that we did, they hadn't come back in yet or to purchase. Some of those patients we found that 21 the AHI at the beginning of the study, and it ended up being in the patients that purchased CPAP, their AHI dropped down to 4. 1 month after they purchased, their AHI was further dropped down to 3, and their Epworth sleepiness scale was down to 6. So well under the significant sleepiness level. So from that, we can assume that the level 2 testing is a valuable tool, when it's used appropriately and you have the right trusted and professionals involved. Level 2 testing can be used to rule out sleep disorder breathing. However, when you have 85 sleep disorders, it definitely cannot rule out any other sleep disorders. This is just to give you an idea of what a level 3 test would look like. So you can show that it is valuable in looking, the data that you're looking at is quite significant. And I'll try my little pencil thing again. If you look down here, this top part here is actually a synopsis of a whole night. And then down here, we're showing a 10-minute video, or I think it's a 2-minute video here. And then if you look here, this is your airport. This here, the second line here is your effort. This is your pulse rate, and this is your oxygen saturation down here. Now, because the oxygen saturation drops below 60%, then that's why you have these big black lines, which is patient here. But if you look in the breathing portion, you can see all of these events that are tagged in the pink. Those are obstructive apneas and how many the patient actually did have. So it does give you some valuable information. And then again, this is just brought down so that this would be an hour of the study, just so everyone can see it a little bit clearer, and then what the actual study would look like. So you can actually see the event as well as the oxygen saturation, what the pulse rate is doing, and how the effort looks. Any questions?